Today we are going to look at the anatomy and physiology of the respiratory system. So we'll do it in two parts. In the morning, we'll cover some objectives. And in the afternoon, we'll cover some objectives as we had suggested. And we'll be done with the respiratory system. I think I'll prefer doing it as one continuum so that we do it in the shortest time possible. And also you consolidate the concept easily. I'll start by defining what respiration is. As a matter of definition, respiration is a series of exchange that leads to the uptake of cells, uptake of oxygen by the cells and release of carbon dioxide to the atmosphere, which means we are basically exchanging oxygen and carbon dioxide. What we need to take note of is that it's a series of exchange. So that after those series of exchanges, eventually your body cells will take oxygen and carbon dioxide will be released to the atmosphere. Having said so, we can therefore say that the exchanges occur at three levels. The first level of exchange of the gases is the exchange between the atmosphere and the alveoli of the lungs. This exchange is what we call ventilation, or basically breathing. So you know that you usually breathe in and out. As you breathe in and out, air moves in and out, but there's a lot that is happening to the gases. So that from the atmosphere, we can say that oxygen goes to the lungs, and from the lungs, carbon dioxide gets to the atmosphere. So this is what we call ventilation, or basically breathing. And for this exchange to take place, you need a functioning chest wall. And so we'll be describing the anatomy of the chest wall also, because it's the principal ventilator, basically. That's why in ICU setup, where people may not be able to ventilate on their own, then you have a mechanical ventilator that breathes for them. The second level of exchange is the exchange between the lungs and the bloodstream. This exchange occurs in the pulmonary circulation. So that the key function of the pulmonary circulation is to dispose of carbon dioxide to the alveoli, but also to load oxygen into the bloodstream. So it disposes of carbon dioxide to the lungs from the bloodstream, but loads oxygen into the bloodstream from the lungs. Usually, this is what we refer to as the gaseous exchange, basically. But take note that this is the key function of the pulmonary circulation. The third level of exchange is between blood and the tissue. The exchange between blood and the tissues is in such a way that now oxygen comes from the systemic vessels to the cells, and carbon dioxide comes from the cells to the bloodstream, so that we dispose of oxygen to the tissues, but we load carbon dioxide to the bloodstream. This third level of exchange is what is sometimes known as the internal respiration. So there are 3 levels of exchange. What are the functions of the respiratory system? We can state a number of functions of the respiratory system. Of course, top on the list is gaseous exchange, as we've already elaborated. This is to mean that oxygen and carbon dioxide are exchanged by the respiratory system. It simply means that our body takes up oxygen and releases carbon dioxide. And so the respiratory system helps us to do this. Apart from gas exchange, there are other functions of the respiratory system, namely acid-base balance. The respiratory system is important in ensuring that the blood has the correct potential hydrogen. The blood has the correct pH. Well, there are 3 systems that help to regulate the body pH. The respiratory system, the renal system, as well as the blood itself. So with regard to the respiratory system, when there's a lot of acidity in the body, we tend to breathe faster so that we get rid of carbon dioxide. When we get rid of carbon dioxide, the pH of the blood goes up so that at least you get some alkalinity. Now, that act of breathing faster so that you can get rid of carbon dioxide is what we call hyperventilation. So we hyperventilate when there is a lot of acidity in the body. And it also explains to you why when you run around the field, even after you've stopped, you still breathe faster. You still hyperventilate because you want to get rid of the acidity in the blood. All right, the third function of the respiratory system is phonation. Phonation comes from the word phon, and it simply means speech. We use our respiratory system for talking, basically. Specifically, we use the voice box, which we call the larynx, in production of sound. So phonation is production of sound, speech. Usually, speech has 2 components. There is phonation and articulation. The articulation is the modifications that sound goes through. And usually articulation occurs at the level of your mouth. So the oral cavity structures, the palate, the tongue, the lips, the teeth, those are the ones we're using for articulation. But phonation is a primary function of the lung. We can also say that the respiratory system has olfactory functions. Olfaction is a sense of smell. Now, the receptor for the sense of smell is located on the upper part of the nasal cavity. We call that receptor the olfactory epithelium. So as air passes through the nose, that air can be, the chemicals within that air can be sensed by the olfactory epithelium. So we can say that the respiratory system has olfactory function because it houses the receptor for smell, which is on the upper part of the nasal cavity, occupying a region that is about 10 centimeters square. Also, respiratory system is important in helping us to generate effort, or sometimes also to evacuate things from the body. Now, maybe I explain it this way. As with regard to effort, you can imagine when you want to lift a heavy load, let's say it's 1 sack of sugar. If it's heavy, most of the time, you'll find yourself holding your breath. Then you lift. And that's what I mean by generating effort. Or maybe for evacuation, you can imagine circumstances where someone has constipated, so you've gone for a long call and you have to push harder. So sometimes you have to hold your breath as you push. So helps you to evacuate. Or during childbirth, think about a woman giving birth. Okay, for those who have seen that happen or participated in one. Usually the advice we give to the mothers when they're giving birth is to hold their breath, especially when the head of the baby is just at the vagina. We tell the mother to hold their breath and push hard because we want them to generate effort that will be enough to help push the baby out. So respiratory system help us to generate effort that might be required even for lifting loads or for evacuating things from the body. And this is through what we call the Valsava Maneuver. When you hold your breath, then you increase intra-abdominal pressure. We call that Valsava Maneuver. We can consider the respiratory system to have a number of endocrine functions, but I want to explain only one. The alveoli of the lungs usually have some blood vessels around them. So those blood vessels around the alveoli are definitely capillaries. The endothelial cells of these capillaries produce an enzyme. That enzyme is called angiotensin converting enzyme. This enzyme is important in converting a hormone called angiotensin 1 to angiotensin 2. And we talked about this when you're looking at regulation of blood pressure. So you know that the lungs participate in conversion of angiotensin 1 to angiotensin 2. Particularly that one is important, and it's one of the endocrine functions of the lungs that I would want to talk about, or I would want you to remember at least. Another key role of the respiratory system, now maybe not the lungs per se, but the chest wall in general, through the action of ventilation, is that as we breathe in and out, we promote venous return. When the chest wall expands, the pressure within the chest goes down. That pressure is what is usually necessary to help us breathe in. But that same negative pressure is also important in promoting venous return back to the heart from the vena cava. So it helps to return the blood in the veins into the heart, the negative pressure within the thorax that is created when the chest wall expands, that moment that you want to breathe in. Lastly, we can say that the respiratory system has immune functions. And by this, we mean that the respiratory system is able to fight infections. And there are a number of immune mechanisms within the respiratory system that help it to fight infections. For example, the hair within the nostrils can trap some particles, including organisms, so that preventing them from entering the body. So help you to fight infections. we have a number of lymphoid aggregations along the respiratory tree. For example, the tonsils around the pharynx, or maybe you tackle them in your immunology, what we call mucosa-associated lymphoid tissue. Maybe you call them MALT, mucosa-associated lymphoid tissue, or if you specifically refer to the ones in the airways, you must have called them the bronchus-associated lymphatic tissue, others called BALT. Apart from those ones, we also have the cilia within the airways, together the mucus, forming what we call the mucociliary rejection current, which is able to reject infectious organisms away from the respiratory system. Also within the lungs, we have macrophages. So there are a number of immune mechanisms in the respiratory system that help to fight infections. Right, so these are the key functions of the respiratory system. What are the components of the respiratory system? We can look at the components of the respiratory system in two ways. We have the anatomical components and the functional component. Or we can look at it this way. We divide the components of the respiratory system both anatomically as well as physiologically. The anatomical division of the respiratory system recognizes the upper and the lower respiratory systems. The junction between these two is the larynx, and this is the location of the larynx. The larynx is what we others call the voice box. So it means that anything above the level of the larynx falls under the upper respiratory system. Therefore, when you talk of upper respiratory system, we're referring to the nasal cavity as well as to the pharynx. So these two are components of the upper respiratory system. So it is important that you understand that, because many times you'll be talking of a patient having upper respiratory tract infection. You need to know that when you're talking about upper respiratory tract infection, you're referring to infection affecting either the nasal cavity or the pharynx. And so when you talk of the lower respiratory system, we are referring to the region from the larynx downwards. So the larynx itself is part of the lower respiratory system, although you can consider it as the junction as well. Anything from the larynx downwards falls under the lower respiratory system. And that means that the larynx, the trachea, the bronchi, the bronchioles, and the lungs in general fall under lower respiratory system. Now, that was anatomical division. How about functional division of the respiratory system? Functionally, we divide the components of the respiratory system based on what the various components do. There are those components which we consider as being the conducting zone. The conducting zone of the respiratory system refers to the regions that conduct air to the alveolar spaces. So the components that conduct air to the alveolar spaces belong to the conducting zone. Then there are those structures which participate in gas exchange. The structures that participate in gas exchange belong to the respiratory zone. So we talk of conducting zone and the respiratory zone. Conducting zone just conduct air to the alveolar spaces. Respiratory zone participate in gas exchange. We will be looking at the different structures that constitute each of those two categories. So that's how the components of the respiratory system is divided. So therefore, in today's lecture, what are the specific objectives to talk about? We will be describing the components of the conducting zone. We will also be describing the morphology of the pleura as well as that of the lungs. We will also talk about the components of the respiratory zone. And we'll talk about the structure of the chest wall. The chest wall being the ventilator, as I've already told you. These four are the ones we'll handle this morning. Then in the afternoon, we will explain the mechanisms of ventilation. We'll also outline the mechanisms of transport of oxygen as well as that of carbon dioxide. This basically being transported by blood, but you look at the mechanisms. We'll also look at the stages of fetal lung development, and we'll look at congenital anomalies of the respiratory system. So the first four we'll handle this morning, and the last four we'll handle in the afternoon when we meet. I chose to divide it that way according to the timings that you proposed that I will have this lecture. So let's start with the first agenda, which are the components of the conducting zone. Before I take you through the various components of the conducting zone, it is important that we understand that the conducting zone is a path that is followed by air from the atmosphere all the way to the alveolar units until you reach the alveolar units. As long as you've not reached the alveolar units, all those are still conducting zones. But the moment we reach the alveolar unit, it exchanges from being a conducting zone to being a respiratory zone. Therefore, if you are to state the functions of the conducting zone, we can say that the conducting zone conducts air, either to or from the alveoli. Apart from that, the conducting zone also participates in air conditioning. By definition, air conditioning refers to the modifications that air undergoes as it moves along the conducting zone. And there are three types of modifications that air undergo. The air that we breathe in can sometimes be cold, and so that air needs to be warmed. Therefore, the conducting zone warms the air. And the mechanisms that help the conducting zone to warm the air include the fact that the conducting zone is also vascularized. So the blood in the arteries, the temperature in the blood in the arteries is able to be translated to the air that we're breathing in. The air that we breathe in can also be very dry sometimes, and very dry air may not be very good for gas exchange, as it may not be very efficient. And so air that we breathe in is moistened or humidified. Again, the adaptation for humidification is largely based on the vascularity of the airway. Importantly also, the air that we breathe in must be filtered so that particles within the air are trapped in one way or another. Those particles should not reach the alveolar units. And these particles could even just be infections, by the way. And so what are some of the anatomical predispositions that help the conducting zone to filter air? There are a number of things. We had mentioned about hair within the nasal cavity that help to trap particles. We also mentioned about mucus lining of the respiratory tree Then couple that with the ciliary activity of the conducting zone, help to filter and also reject particles. Great. So when you talk of air conditioning, think of warming of air, moistening of air, and filtering of air. Let's go through the different parts of the conducting zone. We start with the nasal cavity. So this is the nasal cavity, basically the nose. The anterior opening of the nasal cavity is what you call the nostrils. You have two of them, the right and the left one. You can call the nostril the anterior nares. The posterior extent of the nasal cavity is this region here, which we call the choana. The choana is a junction between the nasal cavity and the pharynx. This region is called the choana. There's a septum that separates the nose into two cavities, the right and the left nasal cavity. Well, the key purpose of the septum, apart from just separating into two cavities, is to increase the surface area over which air conditioning can take place, because there's a thin septum. Well, we usually believe also that with the presence of the septum, at least you are protected. If there's something that was to block the nose, then it would rather block one side, as it gives you chance to continue breathing on the other side, as that particular blocking structure is being sorted out in one way or another. So it's also a protective mechanism, so that the nasal cavity is not predisposed to total blockage once. The lateral wall of the nasal cavity contains some 3 bony projections. These 3 bony projections are known as tabinets or conchae. They are bony projections which are lined by mucosal membrane, which are lined by mucosa. Mucosa is just epithelium. Now, what is the purpose of these projections? These projections increase the surface area also over which air conditioning can take place. So they increase the surface area for air conditioning. We have the superior turbinate, middle turbinate, and inferior turbinate. Between the turbinates are depressions, and those depressions are called meatai. So the superior meatus, middle meatus, and inferior meatus. We have projections and meatai. The projections are called turbinates or conchae. The depressions are called meatai. There's what we call the paranasal sinuses. What are paranasal sinuses? Paranasal sinuses are cavities within the bones that surround the nasal cavity. They are air spaces which are housed by the bones that are surrounding the nose. We name these air spaces according to the bone that is housing them. So the air space within the sphenoid bone is called sphenoid sinus. The one within maxillary bone is called maxillary sinus. The one within ethmoid bones is called ethmoid sinuses. And the one within the frontal bone is called the frontal sinus. There are actually those 4 paranasal sinuses: sphenoid sinus, frontal sinus, ethmoid sinus, and maxillary sinus. The maxillary air sinus is the largest one, basically. One wonders the role of these sinuses. Now, this is how they look like in CT scan. So this is the maxillary air sinus, the largest. This is a nasal airway. Now you can see those projections I was telling you. These are the conchae. So like this is the inferior conchae. But then these are the ones when the epithelium is inflamed, then it can block the nose. Then you say you have nasal blockage, especially when you have homa. You can block the nasal cavity. When you feel that your nose is blocked, the concha, the one that usually get inflamed. These are the ethmoid sinuses. So we wonder their role, and in as much as their actual function is not really known, it is believed that the paranasal sinuses are important in two ways. One, they provide resonance to voice. You know, you can try, or maybe you've compared before, how your voice comes out when you have homa and when you don't have one. Or you can try talking with your nose blocked vis-a-vis with your nose not blocked and compare the difference in your voice projection. So the paranasal sinuses help to provide that clarity in your voice. We believe so. The other key function might be funny, but it's still thought to be a role. We believe that by putting air sinuses within the skull, at least the weight of the skull bone is not that heavy. So it doesn't give you a lot of work to just be carrying your head around. It makes the weight of the skull lighter. Remember, these are just theoretical functions. The actual role is not established. Okay, after nasal cavity, air moves to the pharynx. So the pharynx is the second component of the conducting zone we are talking about. When air moves from the nasal cavity, it goes to the pharynx. The pharynx extends from the base of the skull here to the upper part of the esophagus there. So this region is what we are calling the pharynx. The other name of the pharynx is the throat. Remember, the throat is a common passage for both food and air. And so it's a tricky zone basically, because food will pass here, air also passes through here. Usually, when food is passing, breathing is arrested so that you don't choke. There are three segments of the pharynx. We name them according to the anatomical region that is in front. For example, the anatomical region in front of this region is the nose. So we call this one the nasopharynx. The anatomical region in front of this is the mouth. So we call this the oropharynx. And the anatomical region in front of this is the larynx. So we call this the laryngopharynx. And basically, they go in that order. Right. I want to say something more about the nasopharynx. The nasopharynx is not just connected to the nasal cavity only. Of course, as we can see, it's also continuous with the oropharynx. But there's another thing I want to talk about. Now, you can see an opening there. That opening is the opening of the Estation Tube. The Estation Tube is also known as the auditory tube. The auditory tube connects the nasopharynx to the middle ear. The other name given to the middle ear is tympanic cavity. So the Estation Tube connects the nasopharynx to the tympanic cavity. The purpose of that connection is to equalize pressure between the middle ear and the atmosphere. I believe you've experienced scenarios where sometimes you're changing altitude. Maybe you are traveling from a lowland to a highland, or maybe it's a flight, for those who have experienced one. Now, as you move, you might sometimes feel like your ear is blocking. And then when you swallow saliva or chewing gum, or you yawn, whatever you do, then your hearing comes back. What those maneuvers do is to just open the Estation Tube so that the pressure within the middle ear is balanced with the atmospheric pressure. So nasopharynx is important in balancing the pressure between the atmosphere and the middle ear through that Estation Tube we are talking about. It is also important, now that we've mentioned that the throat is common passage for both food and air, it is important for you to note that air will pass this way. If you are breathing normally from the nasal cavity, air will go to the nasopharynx, then to the oropharynx, then to laryngopharynx, then to the trachea, in that direction. So nasal cavity, pharynx, larynx, trachea. How about food? Food enters through the oral cavity, then goes to the oropharynx, then laryngopharynx, then esophagus. So what I want to take note is that air passes through all the segments of the pharynx, but food does not pass through the nasopharynx. Food only passes through oropharynx, then laryngopharynx, down to the esophagus. Around the pharynx, we have what we call the Waldeus ring. What is Waldeus ring? The Waldeus ring represents a ring of tonsillar tissue. Tonsillar tissue is lymphatic tissue. This lymphatic tissue is embedded within the mucosal lining of the pharynx. Now, there are just multiple lymphatic aggregations. It's not one continuum per se, but there are aggregations. These lymphatic aggregations are about 6 or 4, depending on how you're counting. Their key role is to provide defense against pathogens which are entering the body. So they provide immunity to the infectious organisms entering the body. And you understand that most of the things that enter the body either go through your nasal cavity or your mouth. And I said most. And because of that, therefore, the pharynx is a strategic location to provide immunity against anything entering the body. Now, what are the names of these lymphatic aggregations? Let me use this image to give you their names. So there's one located here at the roof of the nasopharynx. We call that pharyngeal tonsil. Pharyngeal tonsil. The pharyngeal tonsil is only one. It's located at the roof of the nasopharynx. I want you to look at its anatomical location and think through what would happen to it if it is inflamed. So if it is inflamed, remember, lymphatic aggregations usually enlarge when they're inflamed. So if it is inflamed, it will enlarge this way. Having said so, you realize that if it is inflamed, it will block the upper airway. So inflammation of the pharyngeal tonsil causes upper airway obstruction. In someone there is upper airway obstruction, they will not be able to breathe through their nose. So such a person usually breathes through the mouth. It's a common cause of mouth breathing, and especially in children. But also to trigger something, you can only mouth breathe when you're conscious, when you intentionally do it. How about at night when these children are sleeping? Could be an adult sometimes. How they'll manifest is that now such an adult will just be snoring. Now you know why you snore. It could be because you have an enlarged pharyngeal tonsil. Well, usually more in children than adults though. If an adult is snoring, maybe there's another reason, not necessarily enlargement of pharyngeal tonsils. An enlarged pharyngeal tonsil is known as adenoid. So the common clinical diagnosis that will be stating for these patients is what we call adenoidal hypertrophy. That's a common diagnosis we'll be tagging. It means enlargement of the pharyngeal tonsils, adenoidal hypertrophy. You now know why you snore, and I'm told some people snore, wanapiga kelele paka wanajiamsha. Anyway, that is pharyngeal tonsil. The second type, the second component of the Waldes ring is located here, around the opening of the auditory tubes. So these ones will be two, the right and the left one. We call them tubal tonsils. So they're located around the opening of the auditory tubes. We call them tubal tonsils. From that location, you realize that if it is inflamed, it will block the auditory tube. If it blocks the auditory tube, you can't balance pressure between the atmosphere and the middle ear. So this person will present with hearing loss. They may also present with the ear infections. Tubal tonsils are paired. The third type of tonsils are these ones, located just below the soft palate. So we call them Palatine Tonsils. This is the hard palate because it contains bone. This is a soft palate because it does not have bone. Just below the soft palate, we have Palatine Tonsils. These are also paired, so we have right and left. When these ones inflame, usually you can actually see them. When you tell someone to open their mouth, these are the ones that we usually examine. And then when they're enlarged, we say you have tonsillitis. They can be so large that sometimes they actually kiss each other within the mouth. And so clinically, they present with painful swallowing. When they're inflamed, even if you swallow saliva, you feel like being anesthetized first before you swallow that saliva, because it can be really painful. So in children, they'll present with refusal to feed because it's painful to feed. All right, the last component of the Walde's ring is located on the dorsum of the tongue here. We call them lingual tonsils. You can consider that as one group in the middle. Nothing much about its clinical entity. We would expect that it will give you painful swallowing, but they're not very prominent, so maybe you don't really get a lot of clinical entity with regard to that. So remember I told you that they can be 4 or 6 depending on how you're counting. Pharyngeal and lingual tonsils are midline. Tubal and palatine tonsils are bilateral. Okay, we're now done with the upper respiratory system. So I want us to go to the larynx, which is the junction between the upper and the lower respiratory system. The larynx is made up of many cartilages, many muscles, many membranes. I will not give you the names of the muscles and membranes, but I'll name for you a few of the cartilages, and we'll keep to the large cartilages. So we have what we call the thyroid cartilage. This is the one that actually forms your Adam's apple, or Eve's apple if you wish. That is thyroid cartilage. Below the thyroid cartilage, we have what we call the cricoid cartilage. And I'd want you to feel your cricoid cartilage. So maybe you put your finger first to feel the Adam's apple. Then just below the Adam's apple, you feel a small depression. Just below the Adam's apple, you feel a small depression. Below that depression, there's a ridge that feels like a ring. That ring is a cricoid ring. And beyond that ring, you'll be feeling now the trachea. So it is important that you know where the cricoid cartilage is, because a number of times if you're working in theater, an anesthetist may ask you to give them some cricoid pressure when they want to intubate a patient. If you're a nurse and you don't know where the cricoid is, you'll put pressure on anything there, and you might end up killing the patient instead of helping the patient. So you need to know where the cricoid cartilage is. A number of times you'll be asked to put cricoid pressure. The good thing is that when you go for your clinical practice, again, you'll be shown this is the cricoid. But if you've never heard what cricoid is, you'll be wondering, what are you talking about? Okay, so I've mentioned the thyroid cartilage. I've mentioned the cricoid cartilage. The third cartilage I want to mention is the epiglottic cartilage. Epiglottis is something that controls the opening of the airways when you're swallowing. Basically, it closes the laryngeal inlet when you're swallowing, so that food does not go into the airway, but goes to the esophagus. Remember what we mentioned in anatomy some time back, that epiglottic cartilage is consisting of elastic cartilage, while the other laryngeal cartilages are basically hyaline cartilages. I told you I'll not take you through the membranes and muscles. I've also just mentioned 3 cartilages, but as you can see in this image, there are a number of cartilages. There are 2 folds within the larynx. This fold here and the one below. The fold above is known as the vestibular fold. The vestibular fold is also known as the false vocal cord. The fold below is called the vocal fold. The vocal fold is also known as the true vocal cord. With those 2 folds, we can divide the larynx into 3 compartments. The compartment above the vestibular fold is called the Laryngeal Vestibule. So this region here is the Laryngeal Vestibule. You can call it the supraglottic cavity. Then the region between the vestibular and the vocal fold is called the laryngeal ventricle. And lastly, the region below the vocal fold is known as the infraglottic cavity. So this is infraglottic cavity, this is supraglottic cavity, and this is the laryngeal ventricle. Now, when we are around the larynx, you hear about glottis many times. So that talk about epiglottis, supraglottic, infraglottic. Perhaps it's important that we define what the glottis is. The glottis is the opening, that space between the vocal folds. So this space here is what we are calling the glottis. The space between the two vocal folds. So when the two vocal folds are together, then we say the glottis is closed. When the two vocal folds are apart, then we say the glottis is open. Basically, the laryngeal opening is what we are calling the glottis. Best visualized from what you call laryngoscopy. It's an instrument, a camera basically, that is used to look at the larynx through the mouth. It's a curved camera. And this is how it would appear when that camera is inserted through your mouth to look at your larynx. This is the glottis, the opening between the two vocal folds. What are the functions of the larynx? Well, we've mentioned that the larynx is the entry to the lower respiratory tract. Apart from that, the larynx is the voice box. So it's important for production of sound. The larynx is also important in cough reflex. Cough reflex is still immune mechanism. Well, I believe in your lecture in immunity, you are told that there's something called innate and adaptive immunity. And that in innate immunity, it relies on barriers, anatomical barriers, physiological barriers, chemical barriers, inflammatory barriers, and cellular barriers. Now, the physiological barriers to infection include just coughing, even urination. Those are physiological barriers to infection. So the cough reflex is actually mediated by the larynx, where the larynx usually close and you generate pressure within the thorax and abdomen, and then the larynx opens abruptly so that now that air comes out with a lot of force. That helps you to reject anything within the airway that you don't want. Also, we'd mentioned that respiratory system is important for generating effort for evacuation. This is largely courtesy of the larynx again, because during that moment that we're generating effort, the larynx is the one that closes. It closes so that you can generate effort. Great. After the larynx, we go to the trachea. The trachea extends from the cricoid cartilage, which is at the level of the larynx. And the cricoid cartilage is found in the neck, of course. It extends all the way to this region. That region is known as the carina. The carina is the level of tracheal bifurcation, where the trachea divides into two. Of course, the bifurcation is in the thorax. That means that there's a segment of the trachea which is in the neck, cervical trachea, and there's a segment of the trachea which is in the thorax, the thoracic segment of the trachea. On its wall, the trachea has C-shaped cartilage rings. The cartilage rings are not complete. They are C-shaped. They have a defect posteriorly. But in addition to the C-shaped cartilage rings, the trachea also has smooth muscles along its wall. These C-shaped cartilage rings are the ones that enable the trachea to maintain its patency. They offer some rigidity to enable patency. This is how it looks like histologically. This is the cartilage, which is C-shaped. The defect posterior here does not have cartilage, but it will still have smooth muscle. So this is the lumen of the trachea. Now, the trachea runs in front of the esophagus. So the esophagus will be behind here. And when you have both of them together, this is the trachea with the C-shaped cartilage ring. So the defect of the cartilage is here. And the esophagus is right behind the trachea along that region where there's a defect. Of course, you remember that esophagus will extend all the way to the stomach in the abdomen, but the trachea does not extend that long. From the trachea, we have bronchi. One of the key differences between the trachea and the bronchi is now the cartilages of the bronchi are complete. They are not C-shaped. They are complete. It can either have complete rings of cartilage, or it may just consist of plates, cartilage plates. Instead of cartilage rings, they're now cartilage plates. And the plates are all over. There are 3 levels of bronchi. The first type of bronchus is what we call the principal bronchus. You can call it the primary bronchus. So look, when the trachea comes, it divides into 2, the right and the left bronchi. These right and left bronchi are the ones you are calling the principal bronchus or the primary bronchus. You can call the main bronchus. The air within the main bronchus goes to each lung. But look again, the main bronchus also divide. The divisions of the main bronchus are known as the Loba Bronchus or the secondary bronchus. With that name, you then realize that the Loba Bronchus, the air within the Loba Bronchus goes to each lobe of the lung. On the right side, there are 3 Loba Bronchus, which means the right lung has 3 lobes. On the left side, we have 2 Loba Bronchi, which means on the left side, there are 2 lobes. The Loba Bronchus divide into segmental bronchus. Segmental bronchus are also known as tertiary bronchus. The air within the tertiary bronchus goes to what we call the bronchopulmonary segment of a lung. The bronchopulmonary segment of a lung represents a lung segment that is aerated by a single tertiary bronchus. We have about 10 in the right lung and 8 in the left lung, 10 in the right lung, and 8 in the left lung. The reason why we have 8 in the left lung is because 2 of them are combined. Okay, on the upper side, we have 2 combined. On the lower side, we also have 2 combined. That's why the left lung has 8, the right lung has 10. There's something I want you to get about generations of airway division. You see, from the nose, the air goes to the pharynx without diversion. From the pharynx, the air goes to the larynx without diversion. From the larynx, air goes to the trachea without diversion. But from the trachea, there is diversion. Some air goes to the right, some air goes to the left. So we get the first diversion here. Therefore, we call the principal bronchus the first generation of airway division. And these diversions will be all over, all the way to the alveoli. So the first generation of airway division is the main bronchus. The second generation of airway division is the Loba Bronchus. And the third generation of airway division is the segmental bronchus. These generations of airway divisions are many. We are going to see them. I want you to understand the concept of generations of airway division. All right, those are bronchi. Now we can talk about differences between the right and the left main bronchus. I'm using this diagram to show you the key differences between the right and the left main bronchus. So I want you to look at the diagram and try to appreciate those differences. So from here, this is the right one, this is the left one. We can appreciate that the right main bronchus is wider than the left one. We can also appreciate here that the right main bronchus is shorter. If you look at this length from here to there, is shorter than from here to there. The other difference we can compare is the orientation. Now this one is almost vertical, the right one. The left one is almost horizontal. So this is more vertical, this is more horizontal. We can also compare in terms of the outline. And we can see that the right one is more straight, while the left one is more curved. Lastly, we can compare the number of secondary bronchi each of the main bronchus give us. The right main bronchus gives us 3 secondary bronchi, 3 lobar bronchi. The left main bronchus divides into 2 lobar bronchi. So these are the differences between the right and the left main bronchus. These differences are of clinical importance. This way, look, this is the carina. Because the right main bronchus is wider and more straight compared to the left main bronchus. If you are to have a particle coming this way, it will most likely find itself on the right side than on the left side. It is for that reason that foreign bodies will tend to find themselves on the right more than on the left. So if a child inhales a bean seed, for example, it will most likely find its way on the right than on the left. if there's TB infection, most of them will be on the right compared to the left. The right one is more susceptible to those foreign bodies because of the orientation of the right main bronchus. From the bronchus, we go to bronchioles. What are bronchioles? Bronchioles are still part of the airways, except that they now have narrower lumen compared to either the trachea or the bronchi. Important to note, the bronchioles do not have cartilages on their wall. So the issue of cartilages end with the bronchi, not bronchioles. But also, bronchioles have the highest amount of smooth muscles on their wall. So these are the ones that actually manipulate the size of the airways. When you talk of bronchoconstriction and bronchodilation, much of that happen here because they don't have cartilage, so their walls can actually collapse easily. So if you're asthmatic, usually the trouble is largely at this end. In asthma, there is usually bronchoconstriction, so the airway is narrow. Well, during the asthmatic attack. The bronchioles extend from the 4th to the 19th generation of airway division. Remember, the bronchi were extending from the 1st to the 3rd generation of airway division. Bronchioles extend from the 4th to the 19th generation of airway division. Unfortunately, all of them are named. The good news is that they are named in groups. So it's something you can still know. So what are the types of bronchioles? We have what we call the conducting bronchioles. Conducting bronchioles are bronchioles from the 4th to the 15th generation of airway division. We call them conducting bronchioles. Then the 16th generation of airway division is known as the terminal bronchiole. I want you to note that the terminal bronchiole is actually the end of the conducting zone. The terminal bronchiole is the end of the conducting zone. Because from there onwards, we talk about the respiratory zone, but that actually includes the 3rd type of the bronchioles, which we call the respiratory bronchioles. So respiratory bronchioles are the first component of airway division that have a gas exchange capacity. These are the first component of airway division that has gas exchange capacity. And why do they have a gas exchange capacity? It's because they contain alveoli on their wall, as you can see in these images here. They contain alveoli along their wall, so they can participate in gas exchange. That's why we don't consider them part of the conducting zone in as much as they're bronchioles. They extend from the 17th to the 19th generation of airway division. So these are the different types of bronchioles. All right, so that summarizes the story of the conducting zone. But before we leave that and I give you a break, let's talk about the epithelial lining of the conducting zone. The epithelial lining of the conducting zone is lined by what we call the respiratory epithelium. We looked at different types of epithelium some time back, and we are aware of how we classify epithelium. That if epithelium consists of a mixture of short and tall cells, then we call it pseudostratified columnar. When you have pseudostratified columnar epithelium, you look at whether it contains cilia or not, whether it contains goblet cells or not, whether it contains stereocilia or not. This one has cilia, and so we call it pseudostratified columnar ciliated epithelium. This is respiratory epithelium. Pseudostratified columnar ciliated epithelium. In our lecture in histology, I told you that usually this epithelium also has goblet cells. And so the complete name is pseudostratified columnar ciliated epithelium with goblet cells. That usually distinguishes it from the olfactory epithelium that does not have goblet cells. Anyway, what are the cell types in this epithelium? We have a number of different cell types in this epithelium, and those cells have different functions. The majority of the cells are those columnar cells, which contain cilia on their top. The ciliated columnar cells are the ones that basically form the protective barrier. They form the protective lining. Apart from forming the protective lining, the ciliated columnar cells also waft particles. Because of the cilia, to waft is to beat or to propel the particles because of the ciliary activity. There are goblet cells which produce mucus. The purpose of the mucus is to trap particles along the airway. So now, once the mucus has trapped particles, that mucus is then propelled by the cilia. And so the mucus and the cilia constitute what we call the mucociliary rejection current. The mucociliary rejection current is maybe the most important mechanism of protection against infection in the respiratory system. The mucus and the cilia constitute the mucociliary rejection current. The mucus within the trachea downwards is rejected upwards to the level of the pharynx. The mucus in the nasal cavity is rejected backwards. Don't be tempted to say forwards. It is rejected backwards, again to the level of the pharynx. So you realize everything goes to the pharynx. Then from the pharynx, depending on your habit, you can decide what to do. You can swallow like we all do, or you can spit like some of us do. The basal cells are largely for giving rise to the other stem cells. Giving rise to the other cells. So they are stem cells. They are regenerative cells. We have the granule cells, which are also called the Kulczycki cells. The Kulczycki cells are cells of the neuroendocrine system. They also secrete some hormones. I told you that the respiratory system has endocrine functions. We'll not talk about those hormones today, but maybe another time we'll talk about them when we'll be looking at endocrine system next trimester. The fifth cell type are the brush cells. The brush cells are chemoreceptor cells. They are believed to be sensitive to oxygen tension, so that the chemical they detect, oxygen tension within the airway. The Clara cells are unique only to the bronchioles. We don't find Clara cells in any other region in the airway apart from the bronchioles. All the other cells I've talked about are found all over in the airways, but the Clara cells are limited to the bronchioles. So you don't find them in the trachea, you don't find them in the nasal cavity. The Clara cells secrete surfactant substance. Surfactant is a chemical that reduces the alveolar surface tension. When it reduces the alveolar surface tension, it means that it increases alveolar compliance. It increases the expandability of the alveoli. Therefore, surfactant prevent collapse of the lungs. The mast cells, you must have come across them in immunology. We also mentioned them when you're looking at blood. They mediate allergic reactions. Remember that mast cells are actually derived from basophils, and usually they mediate allergic reactions by binding to, or rather cross-linking, immunoglobulin E. Or rather, the immunoglobulin E is attached to mast cells, and so when the immunoglobulin E is cross-linked, it mediates allergic reactions. All right. I'll want to give you a break now. Okay, we can proceed. We're now going to talk about lungs and pleura. Let's begin the pleura. The pleura is a double membrane that covers the lungs. When it says a double membrane, it means that there's an inner layer and an outer layer. The inner layer is called the visceral pleura. This visceral pleura lines the outer surface of the lung. It is very intimate with the lung surface. This is the visceral pleura. It is very intimate with the lung surface, and where there are fissures, it will also go in along the fissures. A bit difficult to separate from the lung surface. Then the outer layer of the pleura is what we call the Pareto Pleura. This one lines the walls of the pleural compartments, or let me say it lines the walls, the inner side of the chest cavity. We give Pareto Pleura different names depending on the actual wall of the pleural compartment it's lining. For example, the Pareto Pleura that is lining the inner side of the ribs, this one, the blue one, is known as costal pleura. The Pareto Pleura that is lining the upper part of the diaphragm, the green one, is known as the diaphragmatic pleura. The Pareto Pleura that is lining the mediastinum, this other color, is known as mediastinal pleura. And the Pareto Pleura that extends into the neck, that yellow one, is known as cervical pleura. So there are 4 parts of the Pareto Pleura: costal pleura, diaphragmatic pleura, mediastinal pleura, and cervical pleura. The space between the visceral pleura and the Pareto Pleura, this one, is what we call the pleural cavity. The pleural cavity usually contains a thin fluid that functions as a lubricant. It lubricates the lungs so that there's no friction as the lung moves during respiration. There's what we call pleural recesses. Pleural recesses are regions where the Pareto Pleura extends, but the lungs usually don't reach there. And largely they're these corners, like that one, as well as this one. And I want to teach you those two. So this recess is located at the junction between the costal pleura and the diaphragmatic pleura. So we call it costodiaphragmatic recess. The costodiaphragmatic recess is that downward extension of the Pareto pleura, but the lungs never reach there, which means the visceral pleura does not reach there as well. This region is clinically important because if someone has pleural effusion is when you have fluid within the pleural cavity. When you have fluid in the pleural cavity, abnormal amount of fluid in the pleural cavity, that fluid will accumulate here at the costodiaphragmatic recess. And that one can be seen even on chest radiographs. The other one is this one, which we call cupula. Cupula is this upward extension of the Pareto pleura into the neck. Now, this one is particularly important clinically because of its susceptibility to traumatic injury. It may be accidentally punctured because it extends into the neck. If you remember our class in the mediastinum, we talked about the lungs extending to the neck. So usually it's the cupula that's extending to the neck. It can be traumatically punctured. And if it's punctured, then you'll introduce air into the pleural cavity. That is what we call pneumothorax. If you have pneumothorax, it can cause lung collapse. The same way, if you are to puncture the lungs can collapse. So remember cupula, remember costodiaphragmatic recess, and their clinical importance. Okay, we can now talk about the morphology of the lungs. We have the right and the left lung. Each lung has an upper region, which we call the apex. The apices are the ones that usually extend into the neck. The base of the lung at this lower part, the base of the lung rests on the diaphragm. Each lung has three surfaces. The surface facing the ribs is known as the costal surfaces. The surface facing the diaphragm are known as diaphragmatic surfaces, and the surfaces facing the mediastinum are known as mediastinal surfaces. The mediastinal surfaces contain this region here, which we call the hilum of the lung. The hilum of the lung is that region where structures enter or leave the lung through. So which structures enter or leave in the hilum? In simple terms, what are the contents of the lung hilum? So in the lung hilum, we'll have the principal bronchi, which take air into the lung, okay, in or out. We have the pulmonary vessels. The pulmonary artery take deoxygenated blood into the lungs, and that pulmonary artery is targeting the respiratory portion of the lung. And of course, pulmonary veins carry oxygenated blood from the respiratory portions of the lung. Apart from pulmonary vessels, we also have bronchial vessels. There's bronchial artery and bronchial vein. The bronchial artery carry oxygenated blood to the lung, remember that. And the bronchial artery targets the conducting zone. Now, not the respiratory zone, but the conducting zone. Bronchial artery takes oxygenated blood to the lung. It targets the conducting zone. Bronchial veins drain deoxygenated blood from the lungs, of course, coming from the conducting zones. So those are the structures in the lung hilum: the principal bronchus, the pulmonary vessels, and the bronchial vessels. Well, there are also some lymph nodes. We call them hilar lymph nodes, and there's some nerves. The nerves which control lungs, basically, they are autonomic nerves. Each lung has fissures which divide it into lobes. This is the oblique fissure dividing the left lung into upper and lower lobe. The right lung has both the oblique fissure as well as the horizontal fissure. Because it has two fissures, the right lung has three lobes: the upper lobe, the middle lobe, and the lower lobe. So remember, left lung has upper and lower lobe only because it has oblique fissure. The right lung has upper, middle, and lower lobe because it has the oblique as well as the horizontal fissure. Each of the lobes, remember, are aerated by the Loba Bronchus, which we called the secondary bronchus. Now, within the lobes, we have what we call the bronchopulmonary segments. The bronchopulmonary segments are aerated by a single tertiary bronchus. If you remember that story of airway division, the first generation is the principal bronchus, which goes to each lung. Second generation is the Loba Bronchus, which goes to each lobe. We have 3 on the right and 2 on the left. Third generation is the segmental bronchus, or others called tertiary bronchus, which goes to each bronchopulmonary segment. We have a total of 10 bronchopulmonary segments on the right lung and a total of 8 bronchopulmonary segments on the left lung. These bronchopulmonary segments are all named, but that is not within your scope. Just know that there are a total of 10 on the right and a total of 8 on the left. Their specific names is not for your scope. What are the differences between the right and the left lung? We can state a number of differences. One, we've mentioned that the right lung has 3 lobes, the left one has 2 lobes. Apart from that, we've also mentioned that the right lung has 10 segments, the bronchopulmonary segments. The left one has 8 bronchopulmonary segments. So another difference we can state is that the right lung is heavier than the left lung. Of course, you can't see that one, so just believe me. Largely because of the number of segments. The right lung is wider than the left lung. The reason why the right lung is wider than the left lung is because of the orientation of the heart. We mentioned that the heart is more projected to the left. And because the heart is more projected to the left, it means that there's a narrower space on the left to be occupied by the left lung. That is why the right lung is wider than the left lung. However, the right lung is shorter than the left lung. Why is the right lung shorter than the left lung? The right lung is shorter than the left lung because of the dome of the diaphragm. The right dome of the diaphragm is at a higher level than the left dome of the diaphragm. And this is because of the liver. The liver extends at a higher level horizontally compared to the stomach. The liver is on the right, the stomach is on the left. So because the right dome of the diaphragm is higher because of the liver dome, the vertical space available for the right lung is shorter compared to the vertical space available for the left lung. That's why the left lung is taller than the right lung. These are the differences between the right and the left lung. Okay, I want us to finish with the respiratory zone. The respiratory zone refers to regions of the lung where gaseous exchange occur. Regions of the lung where gas exchange take place. We also call the respiratory zone of the lung, we also call it the functional units of the lung. Regions where gas exchange take place. These regions where gas exchange take place has some anatomical features that it will be important to highlight. One of these anatomical features is that the regions where gas exchange occur contain a lot of alveoli. And that is why when we saw alveoli on the respiratory bronchiole, then we call it a component of the respiratory zone. Wherever there is alveolar units, there'll be capacity for gas exchange. And so those are various components of the respiratory zone. The other key difference or other key feature of the respiratory zone is the tissue interface between blood and air. That tissue interface is very thin. And it makes sense because you want a thin barrier for gas exchange. Lastly, these regions contain a lot and extensive capillary network. They are heavily or highly vascularized, again for efficient gas exchange. These are the features of the respiratory zone. So which structures actually constitute the respiratory zone? Let's consider what you're seeing on your left as the end of the conducting zone, the end of the conducting zone. We had called it the terminal bronchiole. The terminal bronchiole divides into airways which look like this. Yes, there are channels, but their channels are interrupted. The walls of the channel are interrupted by alveolar units. These are the ones we called the respiratory bronchioles. Respiratory bronchioles are therefore the first component of airway division with gas exchange capacity. They extend from the 17th generation of airway division to the 19th generation of airway division. If you remember, the terminal bronchiole is the 16th generation of airway division. Okay, from the respiratory bronchioles, we have the airways which look like this. If you follow them nicely, you notice that yes, there's a channel, but we don't see a definite wall because the wall is just full of alveoli. For that reason, we call them alveolar ducts. Alveolar ducts are the second component of the respiratory zone. They extend from the 20th to the 22nd generation of airway division. The unique thing about them is that they're channels that don't have a definite wall because the wall is just full of alveoli. The alveolar ducts terminate into some blind ending sacs, which look like that. They balloon out and they end like that. We call them alveolar sacs, which extend from the 23rd to the 24th generation of airway division. So we call them alveolar sacs. At the center, or rather, multiple alveolar sacs meet at some regions there. Regions where multiple alveolar sacs meet are known as alveolar antra. So the alveolar antra are just junction points. Common communication between two or more alveolar sacs. These four are the components of the respiratory zone. They represent the functional units of the lung, regions where gas exchange can take place. We mentioned that they are heavily vascularized, as you can see here. The alveolar units have a lot of capillaries around them. We also mentioned that they are full of alveoli and that the tissue interface between blood and air is very thin. Let's talk about the alveolus, and specifically the cell types within the alveolus. There are three types of cells within the alveolus. Okay, alveolus is singular, alveoli in plural. Remember, alveoli are the gas exchange units. There are three types of cells in the alveoli. We have what we call pneumocyte type 1. Pneumocyte type 1 is a squamous alveolar cell. This is the pneumocyte type 1. Squamous means flat. So this is one, this is another one. It's flat, and that's why even if the only two here, they occupy a very big surface area compared to the rest because they are flattened out. These cells are the ones that establish the barrier between blood and air. They're the ones that constitute what we call the respiratory membrane that we'll be talking about shortly. So for that reason, we can say that pneumocyte type 1 are the cells which are responsible for gas exchange because the gases diffuse through them. The gases diffuse through the cytoplasm of pneumocyte type 1. The second cell type are called pneumocyte type 2. Pneumocyte type 2 are the cuboidal alveolar cells, which is this one here. These pneumocyte type 2 have two key functions. One, they secrete surfactant chemical. So by now you know two cells that secrete surfactant, the Clara cells and pneumocyte type 2. But remember, Clara cells are only in the bronchioles. Pneumocyte type 2 are in the alveoli. So they are in different sites, but they still produce surfactant. Well, this type of surfactant they produce might not be very identical biochemically, but let's not go into that. For the sake of function, they're all responsible for reducing surface tension, hence increasing pulmonary compliance, preventing lung collapse. The second function of pneumocyte type 2 is that they give rise to pneumocyte type 1. Now, this is to tell you that pneumocyte type 1 is not regenerative. Once a pneumocyte type 1 dies, that's it. These ones cannot divide to give rise to them. So what happens is that the pneumocyte type 2 are the ones that then spread out and lose the capacity to secrete surfactant so that they become pneumocyte type 1. The pneumocyte type 2 can divide, they are regenerative. Then we have pneumocyte type 3. Pneumocyte type 3 are also called dust cells or pulmonary alveolar macrophages. These cells are responsible for clearing debris. They remove debris from the alveoli. So basically, they perform immune functions. They are antigen-presenting cells within the lungs. All right, having talked about that and mentioned that the pneumocyte type 1 constitute the respiratory membrane, let's now talk about the respiratory membrane. The respiratory membrane is a tissue barrier between air and blood. So we can also call the blood-air barrier. The blood-air barrier consists of a number of things. And I want you to follow this keenly, then understand the components of the blood-air barrier. Let's consider this to be the pneumocyte type 1, which means this is the alveolus, which contain air inside it. Then these are capillaries containing blood, which means that these are endothelial cells. Remember, capillaries are lined by endothelial cells. So these are endothelial cells. A capillary, just branching there, containing blood. Endothelial cells are epithelial cells. The same way pneumocyte type 1 are epithelial cells. They are both made up of simple squamous epithelial lining, as you can see. Being epithelial cell, the alveolar epithelium is therefore also having a basement membrane, or let's call it basal lamina. There's a basal lamina of the alveolar epithelium. The same way, there's a basal lamina of the capillary endothelium. So the green represent basal lamina of the different epithelium. Each epithelium has a basal lamina. Great. So with this understanding, let's also remember that on the inside of the alveolus, we have a coating of the surfactant chemical. The one in blue is a coating of surfactant chemical. So if you want to talk about the blood-air barrier, we just want to talk about the barriers, the structures traversed by air, let's say for oxygen, from the alveolus to the bloodstream, for carbon dioxide from the bloodstream to the alveolar. And for the sake of simplicity, let's just follow the one of oxygen, represented by the arrows. So which structures will oxygen go through from the alveolus to the blood? The first one would be the surfactant layer, the one in blue. After that, oxygen will diffuse through the alveolar epithelium, which is basically pneumocyte type 1. So after it has diffused through the surfactant, it will diffuse through pneumocyte type 1. After that, look, the basal lamina of the alveolar epithelium and the basal lamina of the capillary endothelium are fused. So oxygen will diffuse through the fused basal lamina. After that, oxygen diffuses through the capillary endothelium. So this is the respiratory membrane. This respiratory membrane is called the thin blood-air barrier. The thin blood-air barrier is the tissue barrier where gas exchange takes place through diffusion. The gases diffuse through those structures. That is to distinguish it from the thick blood-air barrier. What is the thick blood-air barrier and what is its role? So we've seen this as the thin air barrier. Now look at these zones here. Regions where the basal lamina are not fused. The two basal lamina are not fused. Those regions where the two basal lamina are not fused are filled with interstitial tissue. And so the regions through those segments are the ones that constitute the thick blood-air barrier. So the black arrows represent the thick blood-air barrier. If you are to then talk about the components of the thick blood-air barrier, we mentioned the surfactant layer. We then talk about the alveolar epithelium, followed by the alveolar basal lamina or basement membrane. We talk about the interstitial tissue. We talk about the capillary basement membrane. Then we talk about the capillary endothelium. The thick blood-air barrier is not for gas exchange. It is very thick for gas exchange. This thick blood-air barrier functions as a reserve for fluid accumulation if there is edema. If there is edema within the lungs, the fluid in the lungs will accumulate within the interstitial spaces. This is a safety mechanism so that you do not impair gas exchange unless the fluid accumulation within the lungs is very significant. So there are sites of fluid accumulation in lung edema. It's a protective mechanism for the lungs so that you don't impair gas exchange. Because if they were not there, then fluid will just track through here, will affect gas exchange. Right. I want to stop there. I know we said we'll talk about up to chest wall, but I think we can stop there. We've already done 2 hours. Then in the afternoon, we'll pick from there.